So good morning. Without wasting much time, let me just welcome our esteemed panelists. Uh, Gitu met me yesterday and said, "Kya question पूछ रहे हैं आप? क्या-" So it's a very practical, everyday thing that we see, and some rare cases of endometrial cancer. We are going to discuss it. We're just going to discuss two cases. And I will need to learn the technique of getting the video images of the CT or the CT scan, because I just had screenshot images. So I think as people working in a tertiary center, this is a very common thing I think all of us face, is that a postmenopausal woman living in a rural area presents with postmenopausal bleeding, meets the only doctor available in the region who's a general practitioner, gives some progestins, of course no result, and then goes to the gynecologist, who's the GP tells the gynecologist that you go and do a hysterectomy, and he obliges, or she obliges. And there was a growth in the uterus, and to get the minimum information out of it, a piece of the tissue is sent for the pathologist. Pathologist says adenocarcinoma. So it's a very, very everyday, regular scenario that we face as oncologists. I think for every tumor that happens. So that brings us to the first case. This is a 62-year-old Paris woman who presented with postmenopausal bleeding. She had a CT scan of the pelvis. At least some investigations were done, CT scan of the pelvis. We could not actually review the images because it was so poor quality, only the plates were there. No biopsy was done, and hysterectomy was performed in a local nursing home. Apparently on the report of the CT scan said just normal uterus. Nothing was mentioned about the nodes. The histology was sent, and that was reviewed in a relatively better laboratory, where it said that this was an undifferentiated high-grade endometrial cancer. Less than 50% of the myometrial was invaded, and the ovaries were normal, based on whatever we got. So we reviewed the histopathology, and there was only one slide, and one block was available for the review. It was very poorly fixed, and only the morphology could be assessed, which was an endometrioid carcinoma. And we could not do any immunohistochemistry profile for this patient. We asked for a CT thorax and whole abdomen. We prefer not to do PET scan in our institution. Our policy is to do a CT scan, thorax and whole abdomen. With that, we normally manage our patients. Whole abdomen means upper abdomen and the pelvis as well. So I'm just showing the screenshots of the. So if you can see, can you get the marker, please? I got it. Okay. So if you look at this area just above the aorta, you could see a node, and we had doubts about this area as well in the lesser omentum. There was some thickening in the peritoneum. Anyway, so if you just scroll down a little bit further, you can see the pancreas is over here. So little bit lower down is definitely, you can see between the aorta and the IVC, the part of the duodenum is seen here. A little towards the end of the pancreas, and we can see a mass lesion, a paraotic node. And just going down a little bit further, again, it's separate from the duodenum. Down below, when we start seeing the bifurcation of the aorta, the nodal mass is still there, and even further down, it's going on. Going up to the pelvis, luckily the vessels are spared, and you have a node on the right side, also on the left side, possibly at the vault of the vagina. That's going on. So now coming to my esteemed panelists, what would you think at that stage? So you have a histology which is very ambiguous. You do not know what it's going to do. It is an endometrioid carcinoma. That's all we could know. And there is a huge para-aortic, and pelvic mass. So, all of you, please, what would you think in this situation?
Sir, any radiology before surgery is available?
Any sorry?
Any radiology, ultrasound or CT scan before surgery? It's available?
Before surgery, she had only had a pelvic ultrasound scan,
Huh.
which again we couldn't review the images because the CD was not available. Small images on a plate, and we could not make out but it was reported as normal uterus and ovaries, and no mention about any lymph node at
And so,
that stage.
what is the time gap between the surgery and this present CT scan?
4 weeks.
4
So
weeks.
by the time all these things happened, it was about 4 weeks when she came to us.
And sir, because there is a discrepancy in the outside report and review at our center. So, and surgery and CT scan, lot of diseases there. So I'll go for radiology guided biopsy for
Okay.
confirming my diagnosis.
Okay, okay.
Sir, I would just like to add one thing. Because of high positive predictive value and high specificity, even a PET scan in this situation would be of help to rule out nodal or distant mets.
Yeah, that debate goes on, and I'm going to go into that because I mean, as a surgeon, I need to know how much I need to excise, what to excise, and if I'm unable to do the surgery, if I have to rely on the metabolic response, of course, we would go for PET scan. But when we plan for surgery, we normally stick to a CT scan. It saves money for the patient and gives enough information for us. We need a 1 millimeter slice to assess for surgery. Yes, madam.
In case of final endometrioid adenocarcinoma less than 50%, that is what is query diagnosis. And if this para-aortic lymph node is after radiological discussion is operable, then go ahead with surgery and remove the node, and that will also help in diagnosis.
Yeah. Any other opinion? Anything else?
If it is endometrioid, more likely it will be grade 3 because less than 50% gray myometrial invasion, and with this extensive disease, and you are seeing peritoneal deposit also.
Yeah.
So
it is probably a high-grade lesion based on the history and whatever we see. The tumor has already got large para-aortic lymph nodes. The histology again could not be as because tumor was only a small piece of the tumor was sent, which may not be representative. So we do not have the total picture. Only what we have in total picture is the image, which is showing extensive nodal diseases.
So you said peritoneal deposit also, no?
No, there was suspicious. I mean, in the lesser momentum, there were some areas which could be peritoneal deposit.
If a peritoneal deposit is there above the pelvis, it is stage 4B disease then.
Yes,
It is stage 4B.
but that was a suspicion. Yeah. So, any other opinion? I mean, before either surgery or guided biopsy, I agree. Anything else you will do? So there was a thought, I mean, in our discussion that whether we should do a laparoscopy and see whether there is any peritoneal disease. And the plan was to, yes, okay. And if we do not see any disease, then we can proceed for surgery. That was the plan because huge nodes, and the reason we would prefer to go for surgery rather than chemotherapy, again, it's very personal experience that if I have to have any disease removed after chemotherapy, these nodes will be impossible to remove. So the only chance for us to be able to remove these nodes will be by attempting it firsthand, and there could be serious complications, serious R2 resection is also possible, but that is something discussed with the patient and go ahead. Yes, any other opinion?
So tumor markers.
Tumor markers are all normal. There was no evidence of any peritoneal disease for this patient. Yeah. Normally for endometrial cancer, we do not do tumor markers, but because this lady had a suspicion of peritoneal disease, tumor markers might help, yes. So on laparoscopy, there was no evidence of any peritoneal disease. We went ahead and did a surgery. So she had a laparotomy after the laparoscopy. We did a total oventectomy because we were not sure about the nature of the disease. We also did the lesser oventectomy, that's the suspicious area. Complete para-aortic lymph node dissection was possible. Bilateral pelvic lymph node dissection was done. And then it was a revision of the vaginal vault was also done. She had a very prolonged recovery because due to ileus, and there was one readmission within the 30 days of suspected bowel obstruction, and that was managed conservatively. Now this is the final histology. It was a grade 3 endometrioid carcinoma, P53 abnormal, MMR proficient. 18 out of the 32 nodes we removed were positive. However, the resected margin of the vagina was negative, and both the omental specimens were negative. So what would be your next plan, I mean, about the adjuvant treatment?
So, sir, this looks like stage 3, grade 3 endometrioid with P53 abnormality and with heavy nodal positive status. So, I would like to go ahead with chemotherapy, adjuvant chemotherapy, or we can start with CTRT followed by adjuvant chemo. Both are okay in this setting.
So, will you?
I think in P53 abnormal, we should complete chemotherapy first, because
Okay.
already patient is having nodal metastasis.
Okay.
So we don't know about the systemic disease
Mhm.
because we have not done PET CT.
We had done the omental biopsy and random peritoneal biopsy, I just didn't mention, were also done. All were negative. The only disease that was found were in the nodes up to the renal vein. I mean, if you went up the renal veins, up to that renal vein, all the nodes were dissected. Yes, sir.
If there is no other disease, so with so much node positive, I think EBRT, extended field, should be started.
So, I mean, again, P53 abnormal. So there is something of a combination I think we should think of. So what, yes, any other opinion? Tell me, please.
I also will refer the patient for systemic therapy first, because with such a report, the patient is more
P53
likely
abnormal, sir. We have to
more
do
likely
systemic
to
first.
fail systemically than locally, and radiation has only loco-regional benefit. So systemic therapy
Yeah.
first,
6 cycles chemo followed by
followed
chemo
by
radiation.
chemoradiation. Yes.
So we followed the PROTECT trial protocol with a
Yeah,
slight
yeah.
modification.
High-risk histology,
PROTECT
6
starts with the
cycles chemo.
radiotherapy first, but we, in certain cases, and in fact for logistic reason, majority of the cases, we start with chemotherapy. You give 4 cycles of chemotherapy with paclitaxel and carboplatin, and then 25 fractions of extended field radiation that was given to her. So it's nearly 2 years that patient had this treatment and is keeping well. Okay, so that brings me to the any other opinion, anything, anyone from the how now in the audience would like to make any comment about the treatment this patient? And the main challenge was to choose for surgery, whether we should go for surgery or not. And I think the debate was won by us because what we thought that if we give her chemotherapy first, we will never be able to go back and remove all the disease because it gets stuck. And if it gets stuck to the artery, it may still be dissected free. If it gets stuck to the vein, you never be able to do that. And so high up in the, so we won the toss at that time. Anyway, this is...
So the only other thing I think we may consider doing HER2-neu because she's P53 abnormal, although endometrioid histology.
Yes.
There is some evidence to support HER2-neu positive at relapse, not at
Yes,
this
yes.
point. There is an option of anti-HER2 targeted therapy can be.
That's now we routinely do for all B53 abnormal patients, especially if they're serous carcinoma. We do the HER2, but we keep it reserved for at the time of relapse because the evidence is not so robust about starting at the beginning. But if there's a recurrence, yes, I'm sure this woman is going to get a recurrence at some point. We are lucky that she didn't get a recurrence, and it's just about 2 years. So if she gets a recurrence, then HER2 will help us.
So
But
we
it's
can
not-
do ER-PR in this patient. ER-PR.
Yeah, PR we do. Again, it's a prognostic marker, the insulin receptor, more than telling us what to do because, yeah. Okay, next case is, again, a short case, very similar situation. This time she actually went to a gynecologist, a 57-year-old para-2 woman. She presented to the gynecologist with a postmenopausal bleeding, and luckily that she was examined by the gynecologist. There was a growth in the cervix, and this was a biopsy was taken, and by that the gynecologist knew that it looks malignant, and so she was sent to us. The report was adenocarcinoma of the cervix. When she came to us, she had no comorbidities. ECOG was 1. There was a 3 centimeter growth at the cervix involving both the lips of the cervix. We sent the specimen for histology review, and we did an MRI of the uterus and CT thorax and whole abdomen. The reason we do an MRI of the uterus because of the growth in the cervix, I want to see the extension very meticulously, and CT thorax and abdomen for the metastatic workup. The whole abdomen actually gives us an idea about the course of the ureter, because if there's a growth in the cervix, I'm worried about the parametrium. So that's what we did. So does anybody want to comment on what you see on the screen? These are still images. So I've got a T1 image on this side of the screen, other side a T2 image. Anybody would like to explain? It's a very simple one. So you can see please carry on.
So it looks like endometrial disease going into the cervix more than a cervical primary from the image.
So the tumor involves both the uterus and the cervix, and the epicenter could be at the endometrium. So whenever you get a diagnosis of adenocarcinoma, that gives you a clue whether, but unless you have a proper histology, you will not know whether it's the tumor of the cervix extending into the uterus or the tumor of the uterus coming down to the cervix. Anyway, there was no metastatic disease on the CT scan, but one important thing we found in the transverse image on the MRI uterus, that the right parametrium was involved. You can see there's a small, there's loss of the nice ring you see around the cervix. And this area, you can see some tumor infiltration. So we had a suspicion that the tumor actually is going into the parametrium. Coming back to the histology, it was again a grade 3 endometrial carcinoma. And our pathologist Divya has given all the slides to us with all these descriptions beyond my scope of description. But there was something out of the way in the histology. She said that there were plenty of tumor infiltrating lymphocytes. There are heterogeneity within the tumors. There were ambiguous morphology, and there are like patchy, bizarre atypia. There are tumor giant cells. So finally, she gave the conclusion it's probably it's a grade 3 endometrial carcinoma based on the worst histology she could see. So on the immunohistochemistry, this is something which we were not expecting. Of course, the P53 was actually wild type. It was strongly and diffusely positive for ER, and P16 lacked block positivity. So we knew for sure that it is actually a tumor of the endometrium, grade 3, but P53 wild type. So my question to the panel now, what will be your take at this point regarding planning your treatment?
Sir, I'll plan EUA for this patient, examination under anesthesia, to see for the parametrium.
Okay.
Because so many patients we have seen in our practice, and an MRI they are saying parametrium is involved, and then if you do a EUA, it will be free.
Yeah.
So I'll go for EUA and then decide my plan.
Okay, that's a very fair point. Any other thing based on the histology and yes, ma'am.
And on EUA, if the patient is operable, she'll go for surgery.
Okay. So the other IHC we did was the MMR to check for MSI panel, we call, but it was proficient. There was no deficiency in the MSI panel.
So she is P53 wild and strong ER positive. So good prognosis disease. So good prognosis disease. And what's her weight, sir? Weight of the patient?
that's forgot. I mean, it's not a nothing
not
to
a-
deter her from doing any surgery. And yes, on examination, the parametrium felt free, so we decided for surgery. The question is, if you go for primary surgery, would you go for open or MIS? Surgeons, what do you want to do?
Depends on your expertise. MIS is equally has the same oncological outcomes, so depends on your expertise and the setup available.
Yeah.
And maybe there may be a discussion about type 1 or type 2 hysterectomy, or possibility of a radical hysterectomy because of a possibility of parametrial involvement and a cervical involvement. However, there is no difference again in the oncological outcomes if you do type 1 or type 2. So whatever hysterectomy is done, it should be done, and whichever mode or route one is comfortable with or expert in should be
So
done.
it's a surgeon's choice. What about the involvement of cervix? Because of course, with the LAC trial, we are very skeptical about doing minimal access surgery for cervical cancer patients. We don't do it at all. And this woman had a visible disease in the cervix. So I agree, evidence-wise, we will prefer, there is no evidence to say in favor or against doing a minimally invasive surgery for endometrial cancer, but there is a lesion in the cervix. So what would be, I mean, from that point of view, will there be any difference in your opinion? Any?
Sir, usually during EUA, we apply Schiller's iodine on the vagina and see how much it is taking the stain or not. If it is taking a stain, that means your vagina is free.
So
and
this
if any
is
abnormal,
not a cervical cancer.
but in endometrium also we are doing.
It's endometrial cancer.
Routinely we are doing.
Okay, that's a point. I didn't think of it because the HSIL or whatever you see with cervical cancer extending is normally not seen unless there was another disease happening simultaneously. Yes, for cervical cancer, we always mark if you are doing a surgery to understand the resection margin to vagina. But because it's an endometrial cancer, it was endometrioid endometrial cancer, P16 block positivity was not there. So it is an endometrial cancer which is extending to the cervix. My question was, if I'm selecting a surgery, if I'm selecting a laparoscopic surgery, which is again, from the evidence point of view, there's no doubt. There's no difference. But because there is disease in the cervix, so that is something you should be thinking of what to do. So,
Jaideep, can I make a comment here?
Yes, please.
Yeah, so two things. I think this patient, such unusual thing, we should try to get pole testing report also done first. Yes. And second, although Jitu said there is no difference, etc., but when cervix is grossly involved in a case of endometrial cancer, there is some evidence from retrospective studies from China and Korea suggesting that these patients have poor PFS and DFS, stage 2. Especially in this patient, it's coming out. So my personal preference would be open surgery for this patient.
Yeah, so that's what we did. We did for, of course, the pole testing will not change our surgical management. So we decided to go for open surgery just because of we have something that is unknown. The gas that we infiltrate, whether that disseminates the disease or not, we do not know that. And we already touched on this point that whether we should do a radical or a simple hysterectomy. So now that the parametrium was involved, at least on the MRI scan, would you do a radical or a simple hysterectomy? What would be your?
So to follow the
radical again, if you classify according to Quirley-Monroe classification, which type will you do?
Type B, because we should avoid tumor spillage as well as following oncological surgical principles. So you would end up doing at least a type B, preferably not type C.
So what you do not want is a positive margin. As long as the margins are negative in your surgery, then you are happy with that. Yeah. So, and any additional procedure with the hysterectomy?
Sentinel node, they say that the best results are less than 2 centimeter tumors. This is a 3 centimeter. I guess it would again depend on institution to institution. What has the institution found in their prospective studies? This is not the ideal setup for a sentinel node. So I would at least do a pelvic node dissection.
Total node dissection. Yeah. So the decision we take about high-grade tumors regarding this, we do routinely sentinel node biopsy for all patients, but if it's high-grade, our institutional, the rate of isolated paraotic node dissection in our last audit at our institution is 6%. And again, it's a tumor board decision that more than 5%, although in the breast surgeons prefer go up to 10% for their decision, but 6% is a reasonable, good enough reason to go for paraotic node dissection as well. So that's what we normally do. So we did not do a sentinel node biopsy for this patient. We did a systemic node dissection, and we went for a full node dissection. So pelvic, not just pelvic node only. Again, there is a, it will vary from institution to institution because of our own data, own validation of the sentinel node procedure. Now we do paraotic node dissection if there is high-grade disease. That's what we do. What about omentectomy? Will you do omentectomy?
No, sir. P53 wild type.
P53 wild type. And what
And
about
endometrioid histology.
It's endometrioid grade 3. Any other opinion? Anybody? Everybody agrees on that?
I would at least do a biopsy, at least a 5 centimeter.
Okay, okay. So again, it can probably depend on the on institution. We would not do because again, our institution, we had only had 2 cases where in the last more than 10 years, 2 cases of omental positive disease when there was no visible disease in the omentum. If you have a visible disease, of course you do, but if there's no visible disease on gross introduction, in endometrioid P53 wild type, we would not go for omentectomy. But yes, omental biopsy may be like a large chunk of biopsy, can give you a reassurance that yes, omentum is not involved.
So recently, 15 days back, we operated upon a case, grade 3 endometrioid adenocarcinoma. We had IHC on DNC, it was P53 mutant. And we did omentectomy, peritoneal biopsy, paraortic positive, and microscopic deposit in omentum also.
Yes.
So
I mean, there are very rare instances, of course.
Serious.
Yes.
Final was serious.
So it depends. I mean, there's no complete yes or no about doing an omentectomy. It's not a huge deal to do an omentectomy, at least an intracoronary omentectomy, but it depends on the institution. So she had an open procedure, type B radical hysterectomy, pelvic and paratic node dissection. She had a satisfactory recovery and went home on day 4. Now, the final histology, it was a grade 3 endometrioid carcinoma. Tumor was involving more than 50% of the myometrial thickness. Cervical stroma was involved. All margins were negative. The closest margin was on the right parametrium, as I was saying, it was only 2 millimeters. There was no LVSI. The ovaries, fallopian tubes were free. All the nodes were free. And then, so it was staged as PT2N0. According to the current staging system, it will be stage 2C because it's high grade. But P53 normal, I don't know what to do that at stage. If we had only this much of information, would you go for radiotherapy, chemotherapy, sequential chemoradiation? What would you do? What would you prefer, sir?
So, sir, this case ideally should be discussed in MDT, I believe, because the closest cut margin for the para was 2 mm. So, if we consider that to be positive, it becomes stage 3, grade 3 endometrioid. And
the margins were negative. All the margins were
are negative.
Yes.
Okay. Then considering that it is stage 2, grade 3, and it comes in high intermediate risk category.
Yes.
So, better to go with EBRT alone.
Yeah. So, sequential chemotherapy, will you give chemotherapy to her or not?
She being P53 negative, I would not prefer giving chemotherapy.
She would not need chemotherapy for her. But when you give radiotherapy, will you also give chemoradiation or just a simple radiation?
Chemoradiation can be given because she is grade 3, and I didn't see any comment on LVSI. So
LVSI is negative. LVSI is negative.
LVSI negative.
Yeah.
So even then, considering grade 3, it's better to give adjuvant CTRT.
Okay.
I agree, EBRT plus vaginal brachytherapy. And was pole mutation testing done in this patient?
So that's the question, yes. So our decision will change because of this. Yeah. So if you think about this, for this patient, this is the result. So she was pole exon 9 negative. Sorry, she had it's a pole mutant patient.
So she comes into the category of node-specific molecular profile.
All the nodes were negative. All the margins were negative. Uterus and cervix involved. Uterus and cervix involved, and she is pole mutant.
And ERPR status.
ERPR positive, strongly positive.
So she'll receive radiotherapy for this patient.
You will still give her radiotherapy. How many in the audience will give radiotherapy after this? So, stage 2,
So the
pole mutant. Yeah, tell us.
So, in case of early stage, stage 1, high, intermediate and intermediate risk, those were the patients that were taken in for analysis in PORTEC 4A mostly. So in those cases, if the pole mutation was positive, then we could have de-escalated in those patients. But in such a case where LVSI is positive,
LVSI is negative.
Negative,
LVSI
sorry.
is negative.
Okay. Grade
Cervix
3
is involved,
tumor
no?
and cervix is involved.
Cervix is involved, yes.
Cervix is involved and grade 3 tumor. So in this case, we would go for EBRT followed by vaginal brachytherapy.
Okay.
Stage 1 and 2 pole positive can be categorized as low risk.
Yes.
So we can either observe or just give vaginal brachytherapy.
Okay. So this patient was discussed in our tumor board, and this was actually the first patient where, and also with the patient who agreed not to go for adjuvant therapy because the pole mutation, the evidence in favor of pole mutation was so good, and we were also personally convinced, and that's what we the treating team and the patient decided that she will not go. This is in press. It will be published soon. The results of our institutions. We have got. I mean, I will not use the case number 6. That was of US. So the first 100 cases of pole mutation test. We had 5 cases. None of them actually had. So actually, I was mentioning about this case 3 in this discussion. More than 2 years of follow-up. Nobody has actually had a recurrence yet. All of them are disease-free and alive. Again, it's a long way to wait. I mean, we have to wait for many years, many more years to be able to be so confident. And we need to do more studies on, in advanced cases. So if the nodes were positive, if LVSI was positive, what will we do? I don't think we have the answer to that. Okay. So that brings us to the end of my presentation. I take this opportunity to welcome you all to Kolkata in December. If you just click on agoicon2025.com, I promise you a great experience in Kolkata for Agoicon 2025.
Sir,
Thank
my
you.
one question, sir.
Bol.
Noted grade 3, stage 1 and 2, like in this case, polymutation positive. What about if also that co-mutation with PP3? Would you observe or will give adjuvant therapy?
Sorry, say that question again, please.
Both PP3 mutation positive
So
in
this is a
polypositive.
stage 2C disease without the pole. The moment you add the pole, it is stage 1 with,
Yes.
with pole mutation.
What about if also patient is having mutation positive for PP3? That is co-mutation, both.
Multiple
So it's
classifier
a-
you're talking, no? Multiple classifier.
Yes.
It's a multiple
So
classifier.
both mutation positive pole in PP3.
Yes,
Will you
yes.
observe will give chemotherapy? What
Yes.
adjuvant therapy?
That's a very good question.
Sir,
So multiple classifier, again, you have to take an individual call. At the moment, we had only one case of multiple qualifier because the pole is a driver mutation. If the pole is a driver mutation, so we can ignore the P53 mutant.
Yes.
That is the consensus of opinion right at the moment. lot of more knowledge we need to acquire before we are confident for saying that. Again, a decision taken between the patient and the treating team, what to do with them. So with POL, we are at least until stage 2, involvement of the cervix, no lymph node metastasis, we know that we can be confidently saying no adjuvant treatment is necessary, because the driver mutation, the POL mutation, is a good prognostic mutation.
Thank you.
Amit, any comment you would like to give?
No, excellent panel discussion. Thank you.